This video demonstrates the technique of laparoscopic mesh repair of Morgagni type of diaphragmatic hernia. Hello everyone, I am Dr Rashesh Solanki and I bring greetings from GastroPlus Digestive Disease Hospital, Ahmedabad. The patient is a 55-year-old gentleman who presented with left-sided chest pain, breathlessness on exertion and constipation. Physical examination showed reduced air entry in left lower abdominal zone and unremarkable abdominal examination. He was evaluated with chest X-ray which showed collapsed left lower zone and a suspicious bowel shadow in the left chest. There it is. CT chest and upper abdomen to evaluate the same showed a diaphragmatic defect on left side, suggestive of Morgagni hernia. The defect size was 6 into 4 centimeters. The plan was laparoscopic mesh repair of diaphragmatic hernia. The patient was placed in semilateral position and the trocar placement is shown in the figure. Although the picture shows complete lateral position, it was a semilateral position as the actual operative image shows. The trocar placement is almost a mirror image of laparoscopic cholecystectomy ports, except that the camera port is much cranial, almost midway between the umbilicus and the costal margin. The right and left hand working trocars are in subxiphoid and right mid-clavicular line, and assistant trocar is in the left anterior axillary line. The surgeon stands on the right side facing the patient and the camera assistant is to his right. The laparoscopic trolley is placed on the left shoulder. Let us look at the video now. Placing the telescope inside, we can immediately appreciate the omental adhesions. These were taken down and the contents of the hernia, as we shall see later, and we saw in the CT as well, the transverse colon and the omental were gradually released into the peritoneal cavity. The omentum is taken down as is seen, gradually releasing it from the edge of the defect to define it well. The goal is to define the defect all around to facilitate suturing. The defect is visualized now and the sac and the contents are slowly released. There it is, the transverse colon is released into the peritoneal cavity. It is gradually released all around from the omental and the adhesions to the sac, bit by bit, taking care not to avoid or not to injure it or the pleura. The superior edge is almost defined now and we are working towards the inferior edge. The fat and omentum is released into the peritoneal cavity. Thin-walled sac can be appreciated there, which is divided. There it is, the sac is divided. The defect, the edges of the defect are dissected there. We attempted release of the pleura or decortication, but we thought it was densely adherent and not advisable. The defect closure is now begun with 2-0 ethibond interrupted suture. The closure was done with sliding tumbling knot, and the key components of this knot are leaving a longer tail and making sure all the throws are square so that the knot can slide. If the throws are not square, it will not slide. The knot is being tumbled and then it is slid gradually and sequentially. A center is taken first so that the defect approximation occurs for easier suturing. We soon realized that backhand suturing would be easier, and this was done for subsequent stitches. The bites involves pronation and supination of the wrist. The square knot throws can be seen there, and often by pulling the left hand itself one can slide the knot, and if that doesn't occur one can do it, and after that one has to untumble the knot as well, and couple of throws subsequently complete the knot. Since there was sufficient gap in the defect, this was done to facilitate snug closure, which can be seen later on once the entire closure is achieved. There it is, the final appearance after the closure is seen. Snug knots. The 10 into 15 centimeter mesh is placed and is tacked into its place. It was placed behind the spleen to ensure adequate coverage. And adequate coverage from all sides is essential. We find this capsule from Bard company to be very secure. It requires minimal force and has a hydraulic kind of an action which prevents the tags from slipping. One has to be careful while deploying the tags on the medial side. The final appearance is seen there, which is satisfactory. After desufflation also, that's the final appearance of the post-op course was uneventful. Left ICD was removed on post-op day 5. A comparison between the pre-operative and post-operative chest X-rays can be seen over there, suggesting good expansion. Thank you very much.